Good morning. Welcome to my second progress report. I'm Boglárka Fehér, and my topic is altered vaginal flora in pregnancy. I'm a medical doctor at the Department of Obstetrics and Gynecology at Semmelweis University. I believe that pregnant women will have better outcomes due to professional prenatal care, and I wish to find new possibilities of screening and treatment of genital mycoplasmas in pregnancy. To complete this mission, I'm working currently on 2 projects, and I would like to conduct them both through systematic reviews and meta-analysis. First, let me talk about my first project, which is investigating the effect of genital mycoplasmas on adverse pregnancy outcomes. Plenty of people are affected by STIs worldwide. Each day, more than 1 million of them are acquired because they are commonly asymptomatic. The so-called genital mycoplasmas can also spread by sexual activity. These are ureaplasma ureolyticum, ureaplasma parvum, mycoplasma genitalium, and mycoplasma hominis. Here you can see the prevalence is quite high, both in pregnant and non-pregnant women. Unfortunately, evidence-based guidelines currently have no recommendations on genital mycoplasmas, except for mycoplasma genitalium. The reason of that is the controversial data found in the literature about the pathogenicity. Nevertheless, there are plenty of outcomes they can be associated with. In case of colonization, almost half of the pregnancies can end up preterm. Furthermore, the risk of spontaneous abortion, premature rupture of the membranes, low birth weight, and perinatal death can be unacceptably high. Although all these complications are very dreadful for pregnant women, early detection could be able to prevent them. So my aim is to investigate interrelations between genital mycoplasmas and adverse pregnancy outcomes. To reach this aim, I chose this clinical question. Do genital mycoplasmas increase the risk of adverse pregnancy outcomes? I am going to investigate pregnant women. The exposure is genital mycoplasmas. The comparator is no genital mycoplasmas, and I would like to analyze different adverse pregnancy outcomes. The hypothesis is that pregnant women affected by genital mycoplasmas have higher risk of adverse pregnancy outcomes. By answering this question, I hope that screening and treatment of genital mycoplasmas during preconceptional period and pregnancy can reduce the risk of the related outcomes. I've conducted a systematic search in 3 medical databases, and I got more than 10,000 findings with the search key below. After the duplicate removal and the selection of the articles, we ended up with more than 1,000 eligible full text. As I have a large number of the articles, I'm still at the stage of data extraction, so I could present preliminary results in preterm birth. As they are preliminary, not all the available data are included, so at this point we cannot draw any conclusions yet. Our figures show the association between the exposure of genital mycoplasmas and preterm birth, which means giving birth before the 37th week of gestation, the complete lung maturation. We chose this as our primary outcome because of its clinical importance. Globally, prematurity is the leading cause of death in children under age 5. 15 studies were selected for analysis, covering about 4,000 patients. The studies had retrospective or prospective cohort or case control study design. We performed 2 different subgroup analyses. Our first figures shows the subgroup analysis of the 2 genus of genital mycoplasmas, mycoplasma and ureaplasma. In case of mycoplasmas, including mycoplasma genitalium and hominis, we could find statistically non-significant association, but it showed to be a risk factor rather than a protective one. In case of ureaplasmas, including ureaplasma ureolyticum and ureaplasma parvum, we could find an odds ratio of 1.96, which means that pregnant women infected by ureaplasmas have almost twice more chance to give a preterm birth than women with no genital mycoplasmas. According to the p-value, which was below 0.05, the results were statistically significant. The heterogeneity was quite high. The potential source of that could be the different study design, as well as the authors obtained the samples from different sites, amniotic fluid, placenta, vagina, or the cervix, and they used different diagnostic methods, either PCR or culture, which has different sensitivity. Here you can see the subgroup analysis of the different species. In case of Mycoplasma genitalium and Mycoplasma hominis, the results were statistically non-significant. In case of Ureaplasma parvum, the range of the confidence interval was quite wide, and the results were statistically non-significant. But in case of Ureaplasma uroloticum, we could find an odds ratio of 1.96, which means that pregnant women with Ureaplasma uroloticum have almost twice more chance to give preterm birth than women affected by no genital mycoplasmas. The results were statistically significant, with also high heterogeneity because of the reasons I have mentioned. These results correlates with the previous one about Ureaplasmas. And it suggests that Ureaplasma uroloticum could be responsible for the outcome, but as we do not have enough information about Ureaplasma parvum, we cannot draw any conclusions. I would like to highlight the strengths of our study, which is the large number of the articles. The articles were available for 6 outcomes of interest, and we would like to analyze the mechanism of effect, and we would like to perform several subgroup analyses. However, I also have to highlight the limitations, which is high heterogeneity. And we have to exclude several articles because they did not differentiate the types of the mycoplasmas. We could include mostly observational studies, and the presence of the co-infections could be confounding. Here you can see the progress of my project. We are at the stage of data extraction, and we are finished with the half of the articles, which we have the full text. Briefly, let me introduce my second project, which is investigating the effect of different regimens used for bacterial vaginosis in pregnant women. Bacterial vaginosis is a shift from the relative abundance of lactobacilli to a microbial diversity, including anaerobic bacteria like genital mycoplasmas. The prevalence of bacterial vaginosis in pregnant women is quite high. Almost the half of the population could be affected. Bacterial vaginosis, like genital mycoplasmas alone, can be associated with similar outcomes. The risk of the preterm birth is the highest. According to the guidelines, the traditionally used antibiotics to treat bacterial vaginosis are metronidazole and clindamycin. The alternatively used drugs could be daqualinium chloride. Unfortunately, just a couple of guidelines mention alternative regimens, although they could have less side effects and better effect on vaginal flora by preserving lactobacilli. Therefore, they could prevent relapse and improve maternal quality of life. The most conclusive studies are limited to non-pregnant population. Investigations in pregnant women examine only the effect on preterm birth, and the alternative regimens are not involved. So my aim is to investigate the effectiveness and safety of the treatments of bacterial vaginosis in pregnancy. I chose this clinical question: which regimen is the most effective to treat bacterial vaginosis during pregnancy? I'm going to investigate pregnant women with bacterial vaginosis. The intervention and the comparator would be different regimens, and I would like to analyze several outcomes, like adverse pregnancy outcomes, the reduction of bacterial vaginosis, the symptoms, and the relapse. My hypothesis is that alternative regimens have the same or higher effectiveness and safety in bacterial vaginosis treatment compared to traditional antibiotics. And the implication would be that effective treatment of bacterial vaginosis in pregnancy can reduce the risk of adverse outcomes and improve maternal quality of life. After the preliminary research, we ended up with more than 3,000 findings using the several domains of our search key. I have plenty of key articles which proves that my topic is feasible, and I'm going to submit the prospero soon. To summarize, here you can see my future plans. I would like to finish both of my projects until the beginning of next year. Let me finish my presentation with a thought-provoking quotation by Mahatma Gandhi: "Be the change that you wish to see in the world." Thank you for your attention.
Thank you for your presentation. I would like to ask regarding for your first project, there were any other co-funding factors in preterm birth, like age, socioeconomic status, or whatever, and what was the weight of them?
Actually, there are several confounding factors which could be. First of all, we would like to analyze the previous obstetric factors, like previous preterm birth, previous abortion, and the cervical incompetence, multiple pregnancies, because these also could cause preterm birth. And the other confounding factors, the most important one is the co-infections. So that's why we would like to make a subgroup analysis based on this, the co-infections by the other STIs, because they can facilitate each other. And the abundance of the vaginal flora is also very important, and the different inflammatory signs. So if it's possible, we would like to analyze bacterial vaginosis, and these are mainly the plans, and the studies were mainly from middle-income countries, but if we have enough data, we would analyze also the localization, of course.
It's a huge project, huge study with, I think, huge effects for our knowledge in this area. Thank you for conducting it. My question is that what will this mean in the clinical practice? After we got your results, what will this mean in the everyday practice?
Thank you for your question. Actually, our main implication would be the screening of mycoplasmas, because therefore we maybe could prevent these adverse pregnancy outcomes. The other implication could be that there are different groups, women with preterm premature rupture of the membranes and women with preterm labor. And in these cases, maybe we could make some risk assessment to predict the preterm delivery, because, and this will help us if expectant management can be managed or not. I'm sorry. Because I have found some studies where they checked mycoplasmas from the amniotic fluid in these groups, and it could predict preterm delivery. So maybe this could help us for that also. Thank you for your question.
Hello, my congratulations with your progress. I have two questions regarding your first project as well. So first, how the mycoplasma was diagnosed? It was just PCR in all studies, or it was microscopy or something else? And the second question is, do all these women were carriers, or they have some signs of inflammatory process already? And how often we need to diagnose this mycoplasma for all patients before pregnancy? So, thank you.
Okay. So regarding your first one, they use culture or PCR mostly, because mycoplasmas cannot be identified by microscopical examination by itself. Regarding your second question, the symptoms, we didn't analyze the symptoms, but we could find some data about the inflammation, because even mycoplasmas cannot be identified by a microscope. Sometimes they made gram staining, where we can see the inflammatory signs. So that's why we also would like to analyze this as a subgroup to identify this. But these infections are mainly silent, so that's why they are quite dangerous too. Thank you for your questions.
In these studies, did they explain how they choose their control group? Because in the first forest plot I saw in the first study was opposite direction, and among 33 control, 22 had preterm. So how can you explain that?
Yes, maybe we cannot use all of the studies involved in these preliminary results, because regarding the study you mentioned, there were just 7 patients in the preterm group and around 37 in the control group, and we can't make an equality because of that. So not all the studies are efficient for analysis, and during the risk of bias, I think we will exclude some of them because of this. Thank you for your question.
Thank you.